So, good morning, friends. Welcome back to Saturday Club of Baroda morning meeting. And today we have with us Dr. Krati Shah. She is a she is a geneticist, and her qualifications are MBBS, MD, and Fellow in Clinical Genetics. She is ULCC Fellow, USSD, California, USA, member of Indian Academy of Medical Genetics. She was trained at St. GS Medical College, Mumbai, and very reputed CMC Vellore. She has authored more than 20 national and international publications, and she won Young Scientist Award by Department of Science and Technology, Government of India. And besides that, we know about her work in genetics, helping a lot of clinicians in coming to final diagnosis in terms of genetic studies. And these days, as we are just discussing before the meeting started, that all pediatricians and clinicians are now much aware about use of genetic studies, but still there is a lot to learn about when to order what kind of genetic study. So she will be talking about the how best to use genetic studies in clinical practice. So over to you, Dr. Krati. Thank you for joining us. And you have about 45 minutes, and then we'll keep 10 minutes for discussion. So over to you.
Yes, sir, I'll finish around 8:40 and
Right.
we'll start. Sir, can you see the screen?
Yes, we can see the screen well.
I'll just check if it's...
Yeah, it's going on well.
Yeah. 1 second. We'll start. Yes. So, so whatever, a lot of times, first of all, thank you so much for this privilege and opportunity to present in the Saturday Club, which is so old. When I came here to Vadodara, I was invited then also to the Saturday Club, where it was physical, and Dr. Satish and Dr. Daksha Shah ma'am was there, and I had to present. So I was much naive, had no experience in Vadodara that time, and it was very young of me who had presented there. So after maybe 11 years, yes, 11 years, I'm again presenting in the Saturday Club. So it's a privilege to come back to the same place where you started. So for me, genetics is, so it's everywhere. We all are, just because they're of genetics. And 5%, these rare disorders, if you see. So I start with this rare disorders. Why? Because everything rare which you see, somewhere or the other, has genetic component to it. So for example, and this is, so when I was in UK, so I had done my fellowship in UK also, which I had not written in CV. So I was in UK for a year, and I had done a fellowship in Bristol. And there we had a lot of support groups. And these support groups are groups by patient, and they support themselves. Here, when I came, there were no support groups. So initially, I started with Down syndrome. That was the first time I knew ki, okay, support groups has to be there. So I actually support all the rare disorders because I see rare disorders. So a day we had this Down syndrome meeting. So not Down syndrome meeting, it was a parent group meeting at this 28th only, last Sunday, this Sunday. And one of the parent came to me that my child is Williams syndrome and not Down syndrome. Can you please add him to the Down syndrome support group, because he doesn't have any friends. So this is the miracle of support group, which like started 11 years back. Now Williams syndrome come to me and say, please add me to the support group. So the genetic diseases, the hidden burden is a patient with rare disease goes through 8 physician visits, 3 misdiagnoses, 7+ years to diagnose before reaching the diagnosis. So there are people who move, and I see every day such patients. For example, yesterday I saw a 21-year-old male came to me and he had dysphagia. I had seen, so he had come with reports. I had seen him a month back, and he had come with reports from, I don't know, he was from a place near Indore, and he had moved like some 15-20 files he had, and he had not reached the diagnosis. So he had dysmorphic nails, he had dysphagia, he had long face. I've not put that case here, but in that case, it was laryngocutaneous syndrome. So it's like a keratosis congenita and laryngocutaneous syndrome, both in one. So it was a compound thing. So yes, these are rare patients, and they go to so much of, and he was being prescribed from, so this patient had come from some doctor in Vadodara, and he had prescribed 40 mg steroids BD. And with such, and there's no need, but then they came to me and I said, no, this is genetic. So to find out that this is genetic, that's enough. I think that's a good help to the humanity. The topic given to me is how best to use genetic studies in clinical practice. The answer is only this one slide. To learn whether you have a genetic condition that runs in your family before you have the disease. To learn about the chance a current or future pregnancy will have a genetic condition or not. To diagnose a genetic condition if you or your child has symptoms, and to understand and guide your cancer prevention or treatment plan. Other places where you can use genetics is recurrent abortions sometimes. So these are the perfect causes. Other causes where I see the patients is they have like 3 recurrent abortions, 4 recurrent abortions, some balanced translocations. So these are other things, patients coming from in vitro fertilization clinic. So these are some other things, but I'll take you a little bit through the testing, so my first 15 slides, I've just told you a brief about genetics so that we know what genetics is. Once I finish those 15 slides, then I have a lot of case scenarios which I see in day-to-day life. I would request you all that once I finish those 15 slides, you can actually ask me questions if you have, or maybe whenever you want, you can ask me questions. You need not go or wait till the last 10 minutes to ask me questions, right? So it would be great if you can ask questions anytime once I finish these 15 slides. So clinicians have plethora of tests. So when they say ki genetic test karna hai, so there are a lot of tests to it. And what are these tests? So this is like 3.5 billion units of DNA code. And what I explain to the patient is, suppose we have a 10 by 10 room, and there somebody enters that room, has 23 shelves in it. Each shelf has 2 books, and each book has at least 3,000 pages. So I just explained, because 3,000 is such a number that this still doesn't go with what is right, because this has 127 volumes and each volume has 1,000 pages. So I'm much lesser than that, but that helps my patients to understand that this is the recipe of what we are. So genome is actually 127 volumes. Then you have exome, which has around 6,000 genes, which are clinically relevant. So when we talk about exome, we just talk about so this genome is a jargon. It's a lot of things which we don't know. So you imagine 127 volumes in 2,000 pages. So that means so many genes. From it, we have only taken some 5,000 to 6,000 genes and found that 5,000, 6,000 genes to be very relevant, clinically relevant. Then we have these gene panels. For gene panels, what we mean by a gene panel is, suppose a child has sensory neural deafness. Suppose a child has sensory neural deafness. Now there are some 100 genes for sensory neural deafness. Then you'll do only that 100 and you don't do that 5,000 to 6,000 genes. Then you have a single gene, and then you have an exon. Only exons of that gene. I'll come to it. Exons, if you want, like for example, single gene means a single page. Exon means a paragraph, right? So this thing has to be very clear, because we are moving right now. We do whole genome sequencing as well, we do whole exome sequencing, we do clinical exome sequencing, we do gene panels, we do single genes, we do few exons also, right? So this is what it is. So when people ask me about genetics, the first thing, like a lot of people would call ki my daughter wants to do genetics, or so the thing is, there are three types of genetics. One is clinical genomic service, which I do, which I see patients and I advise them what to do, which test to do, when to do. It will help you or it will not help you. Second is a gene pool biobank, where you add on, like DNA, you add on of all the people around there. So this is gene pool biobank, that's very different. And there's a basic translational and clinical research. So I can do a clinical genomic service, I can analyze a clinical genetics report, but I'm not into research like basic or translation research. I can do that as well, but I have chosen not to do it. So these are the three parameters of these services. So these are the battery of tests. When you have this G band karyotype, which we initially know from years on. So in this G banding karyotype, what we do is we just count the number of books. We don't do anything else. We just count the number of books there are. Suppose there are 46. So if it's a Down syndrome there, so you have one book extra in the 21st shelf. That is called a G banding karyotype. You find out that. Now fish is little different, where you know what it is the problem and you want to just point out that if it's a 22q deletion, you want to, you know how many steps for 22, so you just put it so that you know that 22q is there in that. So it means that some 100 pages are there in the 22nd book which are missing. So these are the in karyotype and fish, we are counting the number of books, so we are counting the pages. MLPA, this is basically a test where we see the number of exons. So the paragraphs in it, we don't see the full gene. We just see the paragraphs in it. Suppose I'll take you to that once I have the cases. Then there are methylation studies for Angelman syndrome and Prader-Willi syndrome. Then there's ataxia. So they are triplet repeat, like Huntington's you may have heard. So instead of CAG1, there are like, so 20, up to 20 CAG is normal. Now they have some 100 CAG repeats or more than 40 CAG repeats. So when you have these number of repeats are more. So for example, if you want to learn, so the rat is on the mat, the rat is on the mat. If it comes till 20 times, it's okay. But if it is Huntington's, it will come for more than 40 times. Then this is a disorder. A lot of spinocerebellar ataxias are there. In which, so there are some 17 types of SCAs, spinocerebellar ataxias, and all are these different triplet repeat disorders. So as we are seeing, we just need to be aware that there are so many types of, and one test cannot replace the other. Every test has its own value. Then we have Fragile X. Then we have array CGH. So array CGH is basically a higher resolution. Microarray or array CGH is a higher resolution of a G banding karyotype. It's just like cameras. Earlier we have that Nikon cameras where it was not so much of high resolution, but now when you see array CGH, it has a high resolution, or nowadays these digital cameras have very high resolution, right? Then these are mitochondrial panel. When you have a maternal inheritance, you do this mitochondrial panel. Sanger sequencing, where what do you do is actually, you actually read the paragraph. So you have a paragraph, and so paragraph should be not more than 300 words, and you just read the paragraph one by one. That is called a Sanger sequencing. What is a next generation sequencing? So next generation sequencing is a technique where we take the help of a computer and we read lot of exons or lot of pages at the same time. So we understand the difference, that next generation sequencing and array CGH, the difference being array CGH counts the pages, whereas next generation sequencing just counts the error, the edits. Like for example, the rat is on the mat. So these are the simple words they will see. Like we have to, I think, edit the papers or something like that. So it's reading of single sentence or word rather than the whole gene. Newborn screening panels are there, as you all know, which are like biochemical parameters. Single gene sequencing is different. Then you have these specific disease types such as sensory neural deafness, cardiac arrhythmias, epilepsies, we'll see. Then there's a clinical exome testing. So exome or exons are particularly things which are expressed, right? So clinical exome testing. So whatever is clinically relevant, we do this clinical exome testing, but whole exome testing is where plus other exons are also done, which are not clinically relevant. Right now we do this testing. Then there's a whole genome. So more the testing, more data we have basically, right? So this is whole genome sequencing in clinical practice. Whole genome sequencing in clinical practice. This paper, a very recent paper, 2024 paper, very recent paper, they say that we have actually found out, we have captured a lot of rare disorders because of this classification. But the other problem they have is variant classification. So there are variant classification. I'll explain what is variant classification in a minute. But then there are whatever pros we have for a whole genome sequencing, that it is better, we are able to find out more genes from it, new genes from it, we can extrapolate a lot of causative factors for which we had never known the cause. Now we can find out, but there are cons to it as well. So what are the steps in whole genome or exome testing? So this is a wet lab where we actually extract the DNA, we fragment the DNA, prepare the library, we sequence it. Library amplification is done, we sequence it, and the sequence data collection, we collect that data. Then we have these high performance computer where we read the files with the so this will first capture whole of the data in the form of CTGs. For example, CTAG, the sequence of it will all map all the data. And this in bioinformatics, variant calling is some variations are there, if there are some variations. So we compare it to the human genome, the normal human genome, and we find out what it is. And then we do the bioinformatics and see that how different, and is this the same thing which is clinically whatever is the clinical picture of the patient, does it coincide with picture or it doesn't coincide with the picture. So these are all the steps, and it takes around, so the turnaround time is around 4 to 6 weeks for this test, right? So it is a difficult test, and the amount of data they generate is immense. So what are the challenges of doing that? So there's a genetic heterogeneity. So what is genetic heterogeneity? When different gene mutations cause the same disease. For example, there is a dev delay, hypotonia. Now you can get n number of genes. Clinical heterogeneity, when different genetic mutations cause the same disease. There are very different genes, but they're causing the same disease. So that is a clinical heterogeneity. Comorbidity. Sometimes we have genetic mutations, but we cannot find out because this prematurity, birth trauma, sepsis, all are there with genetic disorders. So we are not able to differentiate between the two because of this. Disease progression is faster in children, and switching the diagnostic odyssey to a recipe, right? Very, very fast progressive. So it is difficult, and it takes a long turnaround time. So we don't know what it is. It doesn't come in a day or so. So like, for example, this study says, this is a very recent study which says that out of some 400, in 50% of the times, the management for the epilepsy was changed because the genetic testing was done. So these are some of the data which help us to, which help not me, but all the pediatricians or maybe whoever is in clinical practice to just think of once that would genetics help, right? Not every time it helps. It has helped in epilepsy, but not every time it helps. So we need to be very sure before we do the testing. So I have finished my first 15 slides. I'll start with a case scenario. And once I finish this case scenario, we'll go to questions. So in this, there is a family, there is a brother who is affected with muscular dystrophy. Very simple case. When we see, so this is basically a PCR AFLP, PCR RFLP method. So this is a restriction enzyme. We do a PCR polymerase chain reaction, that is for the DNA to multiply, and then we do this test. So in this, C is the control, which means that exon 8, 13, 6, and 52 are present. These lines show that yes, these are present. This M is a ladder basically to show us what is the weight of that DNA which they have carried. So it actually cuts at those places. But when you see 1 and 2, 3, 4, 5 are again patients, which control patients like me. And 1 and 2 are basically patients where we cannot see exon 8, 13, 6. That means that there is a deletion of exon from 6 to 13. Right? So this is a basic DMD test which we do, and it is for around 25 exons. And all the 25 exons, so there are 78 exons in DMD gene, but we pick the main 25 and we do this testing. This testing we do for different exons. So 4 times, if we do this testing 4 or 5 times, we are able to find out which exons are deleted. So this, you can see, it's a DMD gene, 78, 79 from exon 1 to exon 79. So this is how they are arranged. And down you can see the B, what you can see is a protein, basically dystrophin protein, and it has these microtubules, F actin, and these are 1, 2, 3, what you're seeing, these are the amino acids which have like a bunch of amino acids which are there, right? So if we have a deleted dystrophin exon, so suppose it is deleted from 2 to 13, then there is lack of dystrophin protein, and that is why. So this is all, dystrophin is a part of sarcolemma, having alpha dystroglycan and all. So a very easy case, you diagnose at molecular level whether this is DMD or not. Do the carrier testing for the sister, because sister wants to get pregnant. Tell them that if they want further child, daughter, if it's a daughter, it would be a carrier. If it's son, there's 50% chance of being affected. Typical explain about the disease, make them accept, and so on. Now we give them 2 options. If you are a carrier, then do a CVS 10 to 12 weeks and amniocentesis at later stage up to 18 weeks. If you're not a carrier, no further testing is required and it is fine. So this is a very simple case which we just finished. Now there's a twist in the story when the patients come to me. So brother was tested for this DMD gene. So the first question which comes to me is, what is the cost of DMD gene? So I cannot tell them the cost, because it has first thing is this PCR RFLP which we do. It is for only 25 exons. Second test which we can do is MLPA, which is for all 78 exons. Third test which we do is again a panel for muscular dystrophy. Panel is there. We do that panel to find out whether it is, we do a muscular dystrophy panel, or we can do a whole exome or clinical exome, whatever we want, we can do that to find out where is the cause. So first, if we do this 25 exon thing, and if it doesn't come, then we have to do a MLPA for all 78 exons, or they can decide to do a whole exome straight away. But that these decisions and why this is not coming, why even if it is a DMD, why it is not coming in the first test and it is to come in the second test. So when the patient comes to me, I explain all the 3 options, and they should know. So if I do all the tests, like even I do whole exome testing, then also sometimes I don't find the diagnosis, even if it is, it looks like a Duchenne's muscular dystrophy, right? So what next? So what next is, I need to explain the patient that, so I need to give a picture of what will happen at the first go, so that they are empowered. My work is not to find out academically what it is. My work is even not to give them a diagnosis or give them a what to be done, just a prescription or just a counseling. My aim is to empower the family. And that is the difference between when we see a patient, we empower the family by telling them all about Duchenne's muscular dystrophy in a very I'll not say positive way, but in a very neutral way where they know everything about themselves. It is not about ki, so I tell them, even if they are like studied only fifth standard, or even they are illiterate, they are able to to understand so much of genetics, and they can take a decision. And I always empower them, make the decisions from their side, so that they know what is to be done, rather than I telling them that you do this test. So in genetics, when we see the whole game doesn't turn towards me, I am not the main person, they are the main person, and they need to decide. And I always give them the onus of doing what they want rather than what I want. When they ask me, if you say आपका तो बहुत experience है, तो आप बताइए मैम आप होते तो क्या करते, I said कि nothing is right and nothing is wrong. You should not regret your decisions, and that is the best part. So empowering the patient regarding this DMD type of genetic test, even a very illiterate patient, they would know कि क्या कर रहे हैं हम, क्यों कर रहे हैं. So when they get the testing, suppose they get a testing where after panel also they don't or after a whole exam also they don't get a diagnosis, they are never they never come and fight with me, because they had decided what has to be done. So that is, and they are very confident of whatever they are doing once they know. So once they are empowered, it actually makes a difference. Now brother has passed away. The second thing, brother has passed away at the age of 20 years. Then can we do something? So this brother was there, but brother passed away. Now the sister wants that she shouldn't be a carrier. Sister wants to know if she will get a boy like this. Now what can we do? We don't know the index case. So in genetics, there's a thumb rule that we only investigate the index case. Now index case is not there. This sister is coming. So I explained everything to them about whole exome, what would happen if it is in DMD and we could find in 79 exons, then, and if she is a carrier, we can do a carrier MLPA testing for the sister, and only that. After doing a carrier MLPA, even if it comes negative, so if it comes positive, we do the prenatal. It's very simple. But even if it comes negative, we tell them another thing, that this has come negative, that means that this main thing DMD is not there, but any other thing can always be there, and I don't know what can be there. So out of 100 children who are born who have no family history or nothing, 2 to 3 children would have something or the other, even if we do all the testing. So that also I explain them very well, so that they know that nothing is in our hands. So we explain whatever medically we can to them, but then this. Another twist, instead of brother, now this girl has a sister who has muscular dystrophy. Now what are the chances of? Because we talked about, in this whole scenario, we talked about that the brother had muscular dystrophy. Now instead of brother, we see it's a sister who has a muscular dystrophy. Now what we do? So if a sister has a muscular dystrophy, there are more chances that the sister has a muscular dystrophy of autosomal recessive type and not a dominant or X-linked. So there are very less chances of her. We do the testing, nevertheless we do the testing for the sister, but broadly we can tell her that there are very less chances that there is a recurrence. So this is all the complications of genetics. So now I'll tell you another thing is first, second, third, fourth. So there are 4 types of testing reports which can come, which is very important. For example, if I have a report in my hand, first thing, we could have found out what it is there. Suppose we take a DMD, we take a gene panel, and we can find out, okay, in this gene there is a problem, right? There is a mutation. So this is a positive testing, or we could find out. Second, there is nothing which comes. Everything is just normal. There is nothing which comes. So that means, that doesn't mean that the test is normal. That means, first thing, that we were not able to find the diagnosis, the genetic diagnosis. It may be there, but we are not able to find out. So that has to be made very clear when the test is absolutely normal. Third is a variant of unknown significance. So variant of unknown significance is where there is a change. Suppose the change, the very simple, I'll tell you, the cat is on the map. Now the C has changed to K. The cat, K-A-T, cat is on the map. Now there is a change, there is a variation, but is this variation clinically significant? We don't know. So this is called a variant of significance, variant of unknown significance. We don't know, VUS, it is called VUS. Variant classification is another topic in all. So there are 6 variant of unknown classification is there. So there are 6 variants. So if it is likely pathogenic or pathogenic, then we count it as positive. But if it is benign, we cannot do the prenatal testing. VUS means that you have not got to the diagnosis. It may be there, but we have to still find out other evidences to prove that this is there. Right? So this variant of unknown significance is a very important term which is very much into genetics, and which everybody who uses genetics in their daily practice as a clinician should know what is a VUS and what are the implications of it. So this is another case scenario where 4 years of female, epilepsy and death delay. They have Rett syndrome, prenatal testing done for the subsequent pregnancies. This is Rett syndrome. This is MECP2 gene on X-linked. This is the affected female. So this is a neurodevelopment disorder. They have mental impairment. They develop this purposeful use of their hands and disabled. Now they have mutations in this methyl CpG binding protein 2, which is a transcription repressor. So in the brain, it will not, it will control the expression of other genes, right? So it is essential for the normal brain development, depending on what part. So partial loss is there. Now prenatal diagnosis done, but twice the affected fetus. So what next? We do the Rett syndrome. So Rett syndrome is generally a de novo variant. So what does the word de novo mean? De novo means that it is new. It has not come from the inheritance. So if it is new, it should not come in the next pregnancy. If something is new, so suppose I'm not a carrier and I have a girl who has first is Rett syndrome, so I do a prenatal, and twice I did the prenatal, and twice it is coming that the child is affected with Rett syndrome. If it is de novo, it should not come second time or third time, because it is new, something is wrong. So what do I have? So I have maybe germline mosaicism. So what is a germline mosaicism? That I am normal in somatically I'm normal, but my ovary cells, they have they have this change in the ovaries, which we cannot in any ways measure, right? So till the prenatal is normal and everything comes normal, it's okay. But if it is and there are 1 to 2% of germline mosaicism in, there are cases of 1 to 2% of germline mosaicism in Rett syndrome, and maybe a lot of disorders. But that is the like we cannot do anything about it. But knowing it that this happens helps us. So this is a case scenario where there is CA colon in the maternal family, and 2 sons are affected. We do a MSI IHC, which here we don't do as frequently, because for us mutation analysis is very easy. Now we found out, and we do the prenatal or maybe we do the preventive colonoscopy from 40 years of age, or from first time it has come. That is all normal. Now the twist is, son at 25 years was, whole family is normal. Mother, father, maternal side, paternal side, everything is normal. But now this is son at 25 years of age. He is being diagnosed to have CA colon. Now we did the genetic testing for the son. Mutation came in LH1. Lynch syndrome. So this is Lynch syndrome. Basically, it is caused by the mutation in DNA repair genes, including MLH1. So we found a mutation in this MLH1 gene. Now what we do? So now the parents are 53 years. One parent is 53 years, one parent is 55 years, and son has this. Now what do we do? Now we do for the parents. And when we do for the parents, Lynch syndrome is generally not very de novo. So we do for the parents and we find that there is a variant in, or there is a mutation in the father. So these are the small discrepancies we do for the paternal family then, and we somehow it was not so much penetrated, but this time now the son has got CA colon at 25 years of age. So these are small intricacies. So another twist, the son has got VUS. Now we do a 25 years old son, we find out VUS. Now CA colon, this Lynch syndrome, all the if you see all the mutations in this Lynch syndrome, they have not been very well studied in India, because it was there in European countries or US and all, but here it was not that common. We didn't do the genomics as common. Now this variant of unknown classification has come. What do we do? Do we tell them that? So I had recently a patient where he is a oncosurgeon a resident oncosurgeon in Patna, Gujarati from Anand, but he is doing his oncosurgery from Patna, and he has this VUS. And he was like, ma'am, what should I do? Ma'am, what should I do? But if it is a variant of unknown significance, we cannot do anything. We have to just leave it there and let someday, if this gene, we can find out if it is benign or if it is malignant, it is pathogenic, we need to find out. Otherwise, we are not able, we cannot do anything about the test. So what I was telling, what do we get in genetic results? So normal, pathogenic, variant of unknown significance, and incidental finding. So incidental finding, I'll tell you a very beautiful case I just saw. So there are a lot of cases, but this one I'll tell you. So there is a medical doctor and her husband is an engineer. They had a pregnancy at 5 months where they had dilated pelvic lysis system and urogenicis in one of the kidneys. Now this happened, and they had done the testing. Testing was done. I have not put it specifically because I didn't want to. There's a lot of ethical issues around. So I'll just tell you. So they had a GNE gene which came for this, for the clinical features of this. And GNE is a muscular dystrophy which comes in adults. Now they came to me initially. I said, no, this is an incidental finding. You don't need to do anything about it. Again, this was when they were not pregnant. Then they became pregnant, and once they became pregnant, they were again very anxious, and they wanted to do a prenatal for this GNE. And that GNE was also VUS. So, and because they are very literate and because they know a lot of things, so they were so anxious about it, but we couldn't do, there is no way where we can do a prenatal for a GNE, or even if it is a VUS, or even if it is a de novo, we don't. So these are all the intricacies. I have so many slides and so many scenarios, and it is 8:41. I would like you to question me because this is unending. Do I? Yeah.
Thank you, Dr. Krati, for that informative talk. Now the house is open for questions. I know it's a very complex subject, so
yeah, it is very complex, and I can speak for 24 hours regarding this. So you asked me, I had another 30-40 slides, but it's too much.
So you are like those 123 books with 3,000 pages and all that.
Not that, but so many cases, no? So many cases I can discuss. Yes, tell me.
Yeah. Sir.
Yes.
Good morning, sir.
Yes.
Sir, this is Dr. Geeti Maheshwari speaking. Dr.
Good morning,
Krati, good morning.
Yeah,
good morning. How are you?
Fine, wonderful.
So I just wanted to ask you something that
Yes.
is are bipolar and personality disorders also have some genetic you know thing, and can those patients also have some genetic testing which will help them in terms of treatment?
Yes. Thank you, ma'am. Thank you so much. So the thing is, bipolar disorders, schizophrenia, still, so when patients come to me for this disorder, like for example, the family has two of them have in the family. Now they want for their own child. Suppose my brother and sister are affected with a bipolar disorder, and I have to have my own children. So what do I do? So there's no genetic test which straight away. So there's a that thing still doesn't exist. These are all still polygenic disorders, but there is, if I have someone in the family, there is 14% risk, more than 3 to 4%. So it's a 14% risk that yes, this will show us that increase is there in the family, but there is no specific test which I could do and I can tell you that yes, this is the thing and you can do a prenatal. Not done.
Okay.
So
Okay.
neither for diabetes, neither for hypertension, neither for any, these are all polygenic disorders where we have found a causal association in few of those. Like for example, lupus is there. So they are also there in families, but we have still not found out the specific. If we don't have a monogenic disorder, we cannot do a prenatal. Right?
Okay. Right.
So I think
Okay.
same is true for autism, where we have polygenic inheritance, I think, because
Yes.
the chances of having another child with autism, they range from various studies from 10 to 30% also.
So
So
the thing is,
please
sir,
your comments on autism, yeah, please.
yes, I'll tell you, sir. So autism, sir, no, the protocol right now is if we do a microarray, we do a karyotype as well, and we do a whole exome testing. Before doing these three tests, we see the dysmorphology. So Fragile X and neurofibromatosis are two very common disorders which has to be ruled out before any of these. So what I told you is microarray and whole exome, but in that Fragile X could not get covered. I have a very beautiful case of Fragile X. I'll tell you that case as well. But in that Fragile X case, people don't get diagnosis for long term. So I had a family recently, and when they came to me, I came to know that they're just living opposite of my house. They, the child has autism, 29 years old, autistic child. The sister just got married 6 months back. Family, so they were they came to me and they said that the maternal side of the family they are not in very contact with. And when I took a history for around more than an hour, I came to know that that girl who got married 6 months back is a carrier. We did all the testing and all. So this son is also Fragile X. One son is Canada. He's absolutely normal. This other daughter, she studied till 10th and she has a Fragile X. And now they're planning for this like child, but then she's a carrier. So Fragile X is very common in autism, and we need to, any autism is there and you think there's a hyperactivity and there's a dysmorphology, little long face, and we need to do a Fragile X.
Okay.
After Fragile X, if it comes negative, because Fragile X is a like X-linked and autosomal dominant type, so it has to X-linked dominant, so we have to do Fragile X, and then we do, I tell them, but then this is the protocol. And neurofibromatosis. If we rule out these two, then these CNV and this whole exome is there. So the yield, I'll tell you, is only 5 to 10%. But still we need to, for it is 100% for the family, but therefore we still find out what it is. And then another time when we cannot find the diagnosis, we say it is polygenic. We don't know what are the causative factors.
The other common question is about cost of various panels that you described. So if you can
I'll
just
tell you
give
the
us
cost.
an idea.
Yes, I'll tell you the cost. One thing very important I always tell is whenever we do a testing, whenever we do a genetic testing from any of the genetic labs, the very important thing is we need to talk to the scientific advisor or scientific person who is actually signing the test. Because if it comes a VUS, now what to do? I have ordered, so I don't know much about genetics. I am a normal clinician and I ordered some genetic test and a VUS. Now, what do I advise my patient? What next to be done? Now, that time, if you are in contact with the scientific officer of that company, so any company you choose, talk to the scientific advisor that these are the clinical manifestations I'm sending for this. Now what? Because if it is a straight away report, it's okay. But if it is not a straight away report, which happens many of the times, then what we do? So talking to the scientific officer is very, very important whichever lab you send. The second thing is about the cost. So the cost, if you see a panels and all, is around 12 to 13,000 and whole exome is around 20,000. If you do a MLPA, it is 8,000.
Okay.
If you do a CNV array, it is around 10 to 13,000.
Okay. So
in case of polycystic kidney,
okay, Jagdish, please go ahead.
In cases of polycystic kidney disease, where many families we see where we are not able to trace whether father or mother had polycystic kidney disease or not. And then subsequently we advise to the children to get the screening done. What are the chances of them inheriting polycystic kidney disease and how they get it? Is it mutation?
Okay, so I'll just repeat the question so that I know I'm right or not. So the thing is, you are telling that some child has cystic changes in the kidney, and you are not able to trace in the parents.
Yes.
So autosomal recessive can be there, no, sir? A lot of kidney diseases are autosomal recessive. It may not be autosomal dominant. Then we'll not be able to trace in the family. It would be a carrier not giving any manifestation.
Then it is inherited. Then it is inherited also.
Yeah.
To the child. To the child. The child also gets it.
In adult we diagnose polycystic kidney disease, then we advise child to get the screening done. Child is positive. Then whether that child gets married, will that progeny will have a polycystic kidney disease?
Next time it is 25% chances of getting a polycystic kidney disease. Jalpa, I'm correct, no? Hi.
Hi.
Jalpa is there?
Yeah, Jalpa.
Yes. Jalpa is there.
Yes, ma'am. Yeah, so polycystic kidney is 25% next time.
Yeah, it's a 25%. It's a autosomal recessive condition. So first time it is like when we don't know that parents have it, the second sibling, like first subsequent all pregnancies, there are 25% chance that it will have a genetic disorder.
So antenatal diagnosis is possible.
Yes, prenatal diagnosis is possible.
Yes, and I have one doubt. I sorry I joined late, but ma'am, what is your take on Alport syndrome and genetic? Because lately we are seeing many VUS in Alport and also, especially this Alport syndrome and its genetic is, I think, we as a pediatric nephro are very much in, and one of I think in CMC Vellore only we are doing some study for the same. So I wanted to know.
Yes. So see, it's not about that we are getting more VUSs now. We are actually doing lot of diagnosis. Earlier, we were maybe 10 years from before, we were not doing as much genetic diagnosis as we are doing right now. So because we actually because earlier what was happening is if it is very florid, if it is like 100% sure that it is Alport, we were doing the genetic diagnosis. Now we do it as such also, because see, any disease, when it comes into genetic, it has lot of variability. If NF you say, in neurofibromatosis you see, so one child I would see who is bedridden at 2 years of age, and I see 60 years person having neurofibroma, small neurofibromas only. So there's so much of variability in a genetic mutation. Same way Alport syndrome, there's so much of variability, and we have actually, what we have done is we have done these variant classification criterias are there. There's a paper on variant classifications, like VUS's classification, where it falls, and whenever there is a VUS, if you find a VUS, talk to the scientific officer.
Right.
A phone call, talk to him, because he would definitely, more we do, see, our population is different. It was
Yeah.
done in abroad population. So our population, we are not Caucasians. Second,
Yeah.
we are doing it and in a much variable population now. We are doing much more also. So these are all the factors why we think that VUS has come. And I think that VUS is a pain in the neck actually. again, we are nowhere on the crossroads.
So
Because
VUS is variation of unknown significance, right? I think audience
Yes.
will know that.
Yes,
Kriti,
variant of unknown. Yes, VUS is variant of
Kriti,
unknown significance, which I explained that CAT cat is there and it comes KAT cat. Now there is a change. So there is a variation. Change is basically variation. So there is a variation, but we don't know, is this variation clinically significant or not?
Yes. Yeah, Hemant.
Kriti,
Dr. Hemant, yeah.
I have a question. With so much of VUS, actually, I'll tell you the support group across the nation for childhood cancer and rare disease is so common. Since 5 years, we are running that group. I am part of it since I was in HCG. Second thing is, as an academic question, when you are talking of VUS, nobody has studied that you are studying the DNA. Does it matter whether it is an epigenetic change or hereditary? Question number one. Second is, have you studied the messenger RNA, which our Nobel Prize winner from MSU has studied, whether these DNA changes actually transform into actual syndrome manifestation depends on the ribosome. So don't you think that the messenger RNA transcriptase has to be, some test has to be developed? Because now we are seeing genetic testing every week. Last week I got 4 patients where the management was decided by genetic study.
So, sir, to ask you, to tell you, the thing is ki in genetics right now, what we are doing. So when I told in my talk that when the report is normal, then we, even if it is normal, we don't say that the report is normal. We say that we are still not able to find out what it is. So the research is going on in a lot of field, but what we right now talking of DNA and right now talking of genetics, in that we still, so if it's an epigenetic change or if it's a normal DNA change, management doesn't matter as such. But for us, when we do the diagnosis, when we do the clinical diagnosis, we have totally different test for methylations and totally different test for DNA testing. Both of them, there are totally different tests. So test, so more we are coming, like I had in my slide I had where there are RNA therapeutics have come, like in SMA,
Yes.
spinal muscular dystrophy, and also there is a Spinraza. So there are RNA interference mechanism, there are aptamers, there are a lot of RNA treatments have come now. So it has gone to that level. But when we talk of genetics at present, and we talk of these VUSs, and we talk of the clinical diagnosis right now, they are all into research settings still. So, it is in the pipeline. So when we talk of clinical genetics is just between a research setting and a diagnostic setting. It is between, we are the bridge.
In the last week, I had a giant cell lymphoma in the 32-year-old male where the genetic studies decided whether the R-CHOP treatment would work or not. It is so important.
It is so important everywhere. Yes.
Another giant cell lymphoma of kidney in a 65-year-old male, where the genetic study later on found that these cannot be lymphoma cells, and they turned out to be a benign follicular cell. Geeti Maheshwari would be interested in this kind of thing. Another was a critical care patient last week, which my colleagues propounded that the genetic test found out why this sepsis is not responding. And they started on steroids, and because you found out that it was an immune disorder. So, right from IVF, all the obstetricians and pediatricians, and even cancer surgeons and physicians are using your genetic test. And the support group in India is growing very fast. We have a huge group of rare birth disorders across the India through Lions International.
Yes,
So
yes,
congratulations for raising the awareness
yes,
and
yes, sir.
providing the services mainly.
No, actually, see, in my scenario, when I see lot of these such cases in which we could actually make a difference, and that even one patient is there, that clinical difference we can make in that patient actually helps us. And these type of cases which you are telling are so common nowadays that it is making a diagnosis. We have to just think of it, and it would, if there is any multi systemic disorder which we not be able to find out the diagnosis, all the heads being joined, we can think once of genetics. And so it's definitely very relevant in today's era, definitely very relevant. And some years to come, maybe another 5 to 10 years to come, it would be immense. It would be just much more than. And because we have great volume of patients, and if we have a good referral system, and we just keep data of this all, this would go like, we would be at the top of the world, like China is doing right now. China has so many publications because they have so much of volume, and they are doing very systematically. So yes, we would definitely do it.
Right. A small question as a pediatrician.
Yes.
Suppose that infant has recurrent LRT, I am suspecting cystic fibrosis as well as ciliary dyskinesia. I mean, what test to go for? If we have two such clinical conditions in mind, should we go for clinical exome or whole genome?
No. So whole genome, sir, we don't do right now. Don't do it. Whole genome. So whole genome, I was telling you. So I have another some 40 slides in it, but I'll tell you, a whole genome, no, it gives lot of VUSs, and it will not give you the right answer. Right. So if you have a clinical findings which you think, you do a whole exome.
Okay.
Rather than doing a cystic fibrosis as a pseudo gene, actually. So that is why don't do a single gene, or the most common Delta 508 has only 19% prevalence, 19, only 19%. So even if you do it and you say ki it is normal, it is there's no mutation, that doesn't mean anything. So whole exome or a panel where CFTR is there, that only you have to do, and don't do whole genome also.
What about ciliary dyskinesia? I mean,
it would come. It would come in.
It will cover it.
It covers. You have to give. See, what happens is, I'll tell you how do we find out that which is the gene. No? So when you do give a clinical history to us, in that clinical history, we have a third-party software. Which third-party software, if we write these specific words, like for example, ciliary dyskinesia, it will pull out that genes. And whatever clinical history you give it, due to that, it pull out genes. So better your clinical history, and so in when you see a clinical history, there are some specific findings. That means, like for example, for me, if I see a dysmorphic child, and there is this hypertelorism, there is almond-shaped eyes, there's so much, but these are all non-specific findings. But if I say polydactyly, then polydactyly is very specific.
Right. So are there any conditions where you have to send the samples abroad also? I mean, is everything available in India? Like
right now,
I had one patient of CCHS, suspected CCHS, where we were told by the so-called scientific officer you mentioned about. It's not always very easy to talk to them regarding CCHS, as central congenital hypoventilation syndrome. I was told that not all genetic studies are done in India. We have to send it abroad. I mean, are there any such situations?
I'll tell you, sir. For example, there is DFZ gene for muscular dystrophy that had changes which we were not able to do it in India. Otherwise, if that gene is monogenic, comes in autosomal dominant pattern, autosomal recessive, and you can find out that this gene is there. Like you can see in Google, and you can find out that this gene is there. If that gene is there, and you tell them, nothing is not available in India.
Okay.
India, everything is available. And see, any patient is there and you have such small doubts, you just call me.
Yeah.
कि ये हो रहा है कि नहीं हो रहा है. So this is as simple, but otherwise nothing. You can always actually, I'll tell you, from Australia, from US, from UK. There are a lot of countries from where patients come and we do the testing here rather than there. It takes 3 to 4 months there to do the testing. Here the TAT is only 4 to 6 weeks. Here it is so inexpensive. 15,000-20,000 is nothing. And there it is so expensive. People do IVFs here. They come here from Canada, US to do. There in Canada, it takes 1.5 years to do that IVF procedure is done in a day in India.
Right. Okay, good to know that. Thank you so much.
No,
So any
centers like-
specific thing you have in mind and you're not getting from that scientific office, just call me. I'll tell you. You just message me and I'll tell you. Yeah.
Thank you.
Kriti, the Biotechnology Mission Gujarat has a Gujarat College Center, Saudi Center, and TMC, Tata Memorial, has a huge 3 centers, ISER. And our own children from our own Baroda are doing bioinformatics and genetics in Texas and Max Planck Institute, Europe.
Exactly. See, this patient, this is a case, I don't know you'll be able to see. So this is a case, so I had in my slide, but so I'll tell you, it is a very, they had GSBTM, Gujarat State Biotechnology Mission, and GBRC, Gujarat Biotechnology Research Center. So these people, so I'm the advisor there in GBRC and GSBTM. So they had sent me a patient. So they send me patients here. I don't go to GSBTM, GBRC, whatever clinical patients are there, they would send me here. So they said that this is a village from where, this is a village near Santrampur, and there are 20 patients of the same condition, and we are not able to find out. And how did GSBTM know? So this patient's husband had some relationship with the Shiksha Mantri. J. Santrampur nu hatu. So this is how I got so these patients came to me here. When they came to me here, I saw them, I said, we need to do a genetic diagnosis. They do the genetic diagnosis for free, this GSBTM and GBRC. So they did the clinical finding. They found out that it is TTR gene. And more than 20 people in the same village. So I'm going maybe on 26th of May to this village to tell all these patients, because there's a lot of stigma and they don't tell that I have this genetic disorder. Why? Because they feel that हमारे घर में शादी नहीं होगी फिर, मतलब मेरे बच्चे की शादी नहीं होगी. But if they do, it's a TTR gene. And even I had sent to Dr. Divyesh Patel in HCG. The same patient I had sent there. I said कि आप एक बार देख के बता दीजिए कि बहुत treatment नहीं है, but at least they have got the diagnosis. And I'm going to that village to talk to all the people that do a prenatal testing. 20 people are affected, and they all, more than 20 are affected, and all has this dysphagia and lot of cortical, this kidney problems, this from TTR has lot of things. No, so basically these type of patients do come when we give them a diagnosis. So this GSBTM didn't know which test to do. Test to wo log sab karte hain, but kaun sa test kare? Then I said, you do this test, and it came out.
Right.
I know Anusuya and Badalkar personally.
Thank you all for the very active participation. Thank you, Dr. Krati.
Yeah, thank you, sir. My pleasure.
That's out the purpose. Thank you so much.
Yeah.
We end the meeting here. We meet next Saturday morning again. Thank you all.
Thank you, sir. Thank you so much.
Thank you.
Thank you.